All right, I think I'm going to get started. We've got a pretty good crowd now. So, all right, good morning, everyone. Thanks for coming to Grand Rounds. I'm going to give you a literature review of transplantation. This is my Aspen talk. And so basically we cover the entire previous year's worth of transplant literature. And then I've also thrown in a couple of extra studies that I didn't present up there. So I've divided the talk up into 5 different sections. If I can get this for events. Let's see here, there we go. In the first section, I'm going to talk about the state of kidney transplantation in the United States. And then in the second section, I'll talk about the SARS-CoV-2 virus and how it affected kidney transplant recipients. And then in the third section, I'll talk about a new look at infections in kidney transplant patients, so keeping with the infection theme. And then in the last 2 sections, I'll talk about a couple of problems, vexing problems, which our kidney transplant patients sometimes face, and those are PTLD and polyomavirus. So let's start with looking at the state of kidney transplantation in the United States. So first of all, we have some good news. And the good news is that after years and years of steady increases, the wait list is now stabilized and has remained stable for the last 3 to 4 years. And this is despite the fact that we're adding ever increasing numbers of patients to the wait list, that the curve is flattened. And I'll explain why that is in a few minutes. The character of the wait list is also changing. So we're seeing that waitlist candidates are getting older. So this green line here, everyone can see my cursor? Can you see my cursor? Yeah, okay. So this green line here is patients who are 65 and older, and you can see that they're increasing pretty much more than anybody else. You also see in this magenta line at the top that the greatest proportion of patients are between 50 and 64. So, excuse me, the wait list is getting older. We're also seeing an increasing proportion of Asian and Hispanic patients. So the purple line right here is the Asian patients, and this greenish line is the Hispanic patients. You can see they're both increasing, and the number of white candidates as a proportion is decreasing on the wait list. Now, I said that the wait list is stabilized, and the reason for that is that we're doing more transplants now than we ever have before. So this blue line at the top is the overall number of kidney transplants, and you can see that it's been on a steady and sharp rise for the last few years, and that's because there's been a big increase in the number of deceased donor kidney transplants that we're doing. You can see there's a small blip with living donor transplants, but mainly this is being driven by these deceased donor kidney transplants. So that's why everything is stabilized. But it's not all good news. So unfortunately, we're still not transplanting all the kidneys that we recover. So this is the discard rate. So you can see what the percentage is on the y-axis. You can see that it's remained about 20% for the last 10 to 12 years. And the most common reasons for why kidneys might not get used, why a surgeon might not accept a donor kidney, is if it comes from a donor who's over the age of 55, has diabetes, has hypertension, or has a high BMI. All right, now this slide, let's switch gears and talk about immunosuppression. I'm trying to find a good place for this window here. There we go. Let's talk about immunosuppression. So this slide shows you trends in induction immunosuppression use across the country. And this basically is a binary question, which is asking, are you using induction immunosuppression or not? And you can see this green line here, there's been a steady increase. And this indicates that over 90% of centers across America are now using induction immunosuppression. And then when we look at maintenance immunosuppression, we can see this top line here is patients who are taking TAC, CellCept, and steroid. And you can see that they make up about 65% of patients. But if you look at this green line is patients who are on TAC and CellCept. So if you add these two together, you can see that over 90% of patients are on TAC and CellCept plus or minus steroid. So the maintenance immunosuppression use is very homogeneous. And this has been a big change. It wasn't like this 20 years ago, but everything has become pretty standard across the country. So what does that mean for acute rejection rates? Well, it means that acute rejection rates are incredibly low. So if you look at this column here on the right-hand side, this is the overall acute rejection rate, and you can see that it's about 7%. But if you look at all these different age groups, you can see the acute rejection rate, it ranges from 6 to 9% or so, but it's very, very low. So just to put this in context, in the early 1970s, acute rejection rates were in and around 70 to 80%. And then after cyclosporin was FDA approved in 1984, the acute rejection rate fell to about 40%. And then in the late 1990s, when the anti-proliferatives were approved, the acute rejection rate fell to about 25 to 40%. So this has been really a very remarkable change. So what does that mean for donor graft survival? So it might not surprise you then, after seeing that about acute rejection, to learn that donor graft survival is now reaching an all-time high in the most recent cohorts. So this top line here is the living donor kidneys, and this blue line here is the deceased donor. This is 1 year adjusted survival. You can see that the survival rates for those grafts is really very good. But this also applies to 5-year survival and to 10-year survival. So survival of both donor, deceased donor, and living donor kidneys have been on the up for the last several years, and both very good. So that's graft survival. We also see an all-time high in patient survival at 10 years. So this is the adjusted 10-year patient survival. This is also an all-time high. So short-term survival and medium-term survival of kidney grafts and patients are at all-time highs. So that's really great news. And then this is a new study that I've included in today's talk. I didn't show this up in Aspen because it wasn't published, but this is from a paper in the New England Journal of Medicine from August. And what this looks at is survival of living transplants. So you can see here patient survival and living donor survival in grafts A and C. You can see patient survival and graft survival for deceased donor and grafts B and D. And these are measured across different time eras, so 1996 to 1999, all the way up to 2012 to 2015. And you can see that in every single graph, the curve is starting to get more shallow, meaning that the patient survival and the graft survival is looks like it's getting better. So there's hope that the long-term survival is improving. There's been a bit of controversy. A lot of people accept that short-term survival is improving across the board, but some people suggest that long-term survival hasn't really changed. But these data, this is taken from the SRTR database, give you cause for optimism. So I painted a pretty rosy picture of the states of kidney transplantation in the United States, but you might say that I'm ignoring the 800-pound gorilla in the room, and that 800-pound gorilla, figuratively speaking, is a small SARS-CoV-2 virus particle. This is a transmission EM of a virus particle. It's been colorized. You can see it's got this sort of rim of these projections around the outside of it, and this reminds people of the corona of the sun. So that's where the virus gets its name, coronavirus. So let's talk about the effects of this virus on kidney transplant recipients. So a lot of the literature in the last year in the kidney transplant field was focused on SARS-CoV-2. And so I've broken this down into 4 different sections. First, background, then I'll say about the first wave descriptions, then we'll talk about the immune response to the infection, and then we'll talk about the efficacy of vaccination. So as everyone knows, coronavirus disease, otherwise known as COVID-19, is caused by the SARS-CoV-2 virus, and this was first identified in China in December 2019. This is actually the 7th coronavirus known to have infected humans, and this group includes the MERS-CoV, or the Middle East coronavirus. So when we look at the structure of the coronavirus, it's spherical. Like I say, it has these projections that make it look a bit like the sun. It's 60 to 140 nanometers in diameter, so it's sort of a medium-sized virus. And very importantly, and this will be important later also, it's got 4 surface proteins. So it's got a spike protein, an envelope protein, a membrane protein, and a hemagglutinin esterase dimer protein. But then it's got a 5th protein on the inside, which is shown here in the circle, which is a nucleocapsid protein. And this protein is bound to this RNA. So when you get a natural infection, you develop antibody against the nucleocapsid protein and against all these other proteins. When you get the vaccine, you only develop antibodies against the spike protein. So that's how you can differentiate vaccinated people from infected people. In addition, the entire genome is 26,000 to 32,000 bases long. So this is fairly long as far as viruses go. Polyomavirus, for example, is about 5,000 bases long. Hep C and Hep B are between 3,000 and 10,000 bases long. So this is kind of a big genome. When you look at how coronavirus and how SARS-CoV-2 got to America, you can see that it took 2 different routes. So the first route was a very direct route, and that went from China to the west coast of America, to the Seattle region. And then the second route was an indirect route through Europe, particularly Italy and Spain. And then from Europe, it got to the East Coast and to the New York City region. So when you look at this map, it might not surprise you to learn that the very first reports of coronavirus and of SARS-CoV-2 in transplant patients came from Italy and Spain, and they were quickly followed by reports from the New York City medical centers. So these are all single center reports. You can see that they're all pretty small. They all include kidney transplants, but also some liver, some heart, and some lung. And you can see that the mortality rate, which is kind of a grim statistic, is pretty high. So it ranges from 18 to 30%, but in general, it's about 25 to 28%. After these papers were published, there was a multi-center group that did a study, and this was called the Tango International Transplant Consortium. They published this paper in November of last year. And this was a retrospective cohort study of 144 kidney transplant recipients who were admitted with COVID-19 to 12 centers in the US, Italy, and Spain. So just to show you the locations of the centers, you can see that Denver was one of the centers, and our own Monica Grafals and one of our fellows, Sandeep, from last year, were involved in this paper. And for inclusion criteria, they included all adult kidney transplant recipients with a functioning graft who were admitted between March 2nd and March 15th, 2020. And they excluded patients who did not require hospital admission. So these are only inpatients, obviously. And they also excluded any patients who were included in prior studies. So these are all de novo patients. So in terms of the most common symptoms in these transplant patients on admission, they saw fever and dyspnea in about 67%. Half of the patients had myalgias, and about 40% of the patients had diarrhea. And very importantly, half of the patients developed AKI, so obviously not good if you got a kidney transplant, and a third of the patients required mechanical ventilation. And then the mortality rate was a bit higher in this cohort than it was in the multi-census and the single census studies. So the mortality was unfortunately 32%, so very high. 50% of the patients who went to the ICU passed away. The median time to death was about 2 weeks, but conversely, if you survived, the median time to discharge was about 3 weeks. And then perhaps not surprisingly, there were 3 people who got ECMO, and all those people passed away. So one of the things about what I just showed you about all these studies is that this was early on in the pandemic. And honestly, we didn't really know what we were doing back then. Now, as everyone knows, we're much more aggressive about treating patients with COVID-19 with high-dose steroids, antibody, patients getting vaccinated. So this is a look at our local center right now. This is a slide that I got from Pat Clem, so I want to thank him for giving me this data, but he's been keeping track of what's going on with COVID-19 in our renal transplant center. So this is data as of last September 14th. So far we've had 225 patients who have tested positive. 41 patients have been diagnosed within the first year of transplant. The death rate is 10%. Now keep in mind that this death rate includes outpatients. So it's outpatients plus inpatients. So that's why it's a bit lower than in some of those studies that I showed you. Also, we're treating patients more aggressively. And then interestingly, we've had 33 patients who've had a breakthrough infection. So this is after complete vaccination. This has actually now changed. We actually have 4 patient deaths in patients who are fully vaccinated. We unfortunately just had one in the last week. And then since May 1st, about 73% of the cases have been breakthrough cases. And then in terms of race ethnicity of the cases, 41% are Hispanic, 6.2% are Black, 47% are non-Hispanic, and then 5.4% are other. So that's what things look like on the ground at our center. All right, so that's the first wave descriptions and outcomes. And now let me tell you about the immune response to infection. So one of the big questions that was being asked in the transplant field was, if you get this infection, can transplant patients who are immunosuppressed respond to it? And probably the biggest study that looked at this was published last year in November in AJT. And this was a study of hospitalized kidney transplant recipients with non-severe and severe COVID-19, and they looked at the serological response to the SARS-CoV-2 virus. So if you look at this graph first, you can see on the y-axis, there's the rate of positive serology. This red line here is patients with, this is the IgM. The blue line is the IgG, and then the purple line is both antibodies combined. And you can see that the curves in both these curves increase steadily up to about day 28, and then they plateau and stay plateaued up till day 59. So looking at the numbers, these authors got 116 samples from 35 patients, so they got 3 sera per patient. There were 4 non-survivors. All of those patients were seronegative at the time of death, and you can see that they passed away quite early on. All the survivors were seropositive by day 14, and then everyone achieved a stable. Everyone who survived achieved a stable IgG level that was maintained until day 59. suggesting that there was persistence of immunity more than 2 months after the infection. So what this paper showed was that our patients, the transplant patients who are immunosuppressed, can show a humoral response to the SARS-CoV-2 virus. I didn't show you this data just in the interest of time, but they also showed that the plasma viral load was associated with morbidity and mortality, whereas the viral load from the nasopharyngeal swabs was not. So the swabs for the nose are not good for a correlation, but the plasma viral load was. And they also showed that SARS-CoV-2 virus shedding was very prolonged in kidney transplant recipients. So people then started to say, well, if you can respond to an infection, how about to a vaccine? Can you mount a response to a vaccine? So the data regarding vaccination has just started to come out. This is one of the first studies. It was published in JASN a couple months ago in June, and this is from France. And what these authors did was to look at the serological response to the Pfizer vaccine in 78 dialysis patients, 74 kidney transplant recipients, and 7 healthy controls. And what they looked at was the antibody titers against this virus at all these different time points. All the patients were screened for anti-nuclear capsid antibodies. So remember, this was a marker of natural infection. So if the patients had this antibody, they were removed from the study because they were looking only at the response to the vaccine. And then an important point is that these authors identified that an antibody titer greater than 13 AU, AU stands for arbitrary units. If you're above 13 AU, you were considered as having neutralizing antibodies. So you wanted to be above that level. So here on the y-axis is the AU, and on the x-axis here are the 3 different groups. So if we look at the controls first, shown here in green, this dashed line here is that 13 AU cutoff that I was telling you about. And you can see that all the controls very quickly get above that cutoff and remain above that cutoff and have a good antibody level that's maintained through day 58. If you look at the dialysis patients, you can see that a whole ton of them did not develop antibodies sufficient to get above the cutoff, whereas another fairly large number did. And then these are the transplant patients here in red, and you can see that only 4 patients, 4 or 5 patients got above the cutoff. So looking at the numbers, on day 36, the controls, these green ones here, 100% of them had a positive antibody, and their antibody levels were 1,082. These dialysis patients, about 81% had positive antibody, but their antibody levels were only 114, so still above the cutoff, but much less than the controls. And then the kidney transplant recipients, only 4% managed to get above the cutoff. So not great results for the kidney transplant recipients. So after this study came out, there's another study that came out of Israel. This was published, when was this published? In April. And they looked at the humoral response to full vaccination with the Pfizer vaccine. So this is after you got both doses. And they looked at 136 kidney transplant recipients, so a little bit bigger, versus 25 controls. And these controls were healthcare workers, none of whom who got immunosuppression. So only participants, again, with negative serology to the nuclear capsid protein were included. The blood was collected 20 days, 10 to 20 days after the second vaccine dose. And then for this study, you had to have a level greater than 15 to be considered positive to have neutralizing antibody. So these are the demographic characteristics. There were a couple of slight differences. So in the kidney transplant recipient group, they tended to be a bit older, tended to be a bit more female, but otherwise the groups were pretty comparable. So here again on the y-axis is the AU, the arbitrary units. Here's the cutoff that you want to be above. Here are the controls in the study group, and you can see immediately that the controls all had a very good response. Whereas in the study group, a number of the patients had a decent response, whereas a number did not. So looking at the actual numbers, all the controls had a positive antibody response versus 37.5% in the transplant recipients. If you had a kidney transplant recipient and the median antibody level for the kidney transplant recipients as a whole was 5.9 as compared to an antibody level of 189 in the controls. And if you were, sorry about that, if you were a seropositive kidney transplant recipient, your antibody level was 71.8. So because, oh, and then let me show you this. So these are risk factors for why you would develop a negative humoral response. So age, triple immunosuppression, high-dose corticosteroids, and maintenance MMF were all risk factors for why you might not develop an antibody response. And then in follow-up, two of the recipients who were in the seronegative group developed severe COVID-19 infection. There was no infection in the seropositive group. And then people have been talking about a theoretical concern that if you got vaccine, you might develop an episode of acute rejection. So in this paper, they took pains to make sure that they looked at acute rejection, and they found no evidence of biopsy-proven acute rejection after you got vaccine. So if we just summarize those two studies about the vaccine, these were both looking at Pfizer vaccine, and they showed that the response rate was 4% to 37.5%, so not great. The antibody titers, even in the responders, was quite low. And the risk factors for a poor response were older age, triple immunosuppression, high-dose steroids, and the presence of MMF. So because of this poor response, the French National Health Authority started to recommend the use of a third dose. And what happened in France was published in a letter in the New England Journal of Medicine in June of this year. And what this group did was look at 101 consecutive solid organ transplants who got 3 doses of the Pfizer vaccine. So the third dose was given 61 days after dose number 2. So if you look here at this first graph, here on the y-axis is prevalence of the SARS-CoV-2 antibody. And then this is obviously you can see on the x-axis the time after each of the doses. And you can see that with every vaccine dose, there's a steady increase in the prevalence of SARS-CoV-2 antibodies. And then if you look at the second panel here, here's the cutoff that you want to be above, the dashed line. And you can see that the titer levels also increase steadily as you get more vaccine. So looking at the numbers, 44% of the patients who were seronegative before the third dose became seropositive afterwards, and they had an antibody titer level of 690. In addition, there was 40 patients who were seropositive before they got the booster dose, and then 4 weeks later, they were still seropositive, but their antibody titer had increased from 36 up to 2,676. So there's really a giant jump in how much antibody they had. So the patients who did not have an antibody response, again, tended to be older, tended to be on more immunosuppression, and tended to have a low EGFR, but the EGFR wasn't bad, I mean, it's 45, so not super low. COVID-19 did not occur in any of the solid organ transplants after receiving 3 doses. And again, this group saw no acute rejection even after getting 3 doses. So hopefully putting that problem to bed. So after this study came out, a lot of people were asking in America, in our patient populations, can we get the booster dose? So the American Society of Transplantation, that's AST, and its sister organizations, the Surgeons Organization, the Heart Organization, the Lung Organization, they all put out a joint statement. This came out on July the 8th of this year. And they actually said, well, even though those studies didn't show any acute rejection, we've had more than one report of acute rejection occurring temporarily after a booster, and the actual risk of acute rejection is not known. In addition, they said that the booster doses were not recognized under the United States end user agreement, but international regulations may vary. That's why the French were able to do the study that they did. So they said at that time that they only recommended booster dosing in the context of clinical research studies. So that was in July. And then 1 month later in August, a third paper came out. This one came out of Canada. Again, as a letter to the New England Journal of Medicine. This was a double-blind randomized controlled trial looking at a third dose, this time of the Moderna vaccine versus placebo. So these authors gave Moderna versus placebo in a 1-to-1 ratio. And this is the dosing schedule that you see right here, and the placebo was saline. So the primary outcome in this study was the level of anti-spike protein greater than 100, and they derived this outcome level is pre-specified, and it was based on a protective challenge study that they'd done in primates before this paper came out, and also they verified it in a large clinical cohort and showed that this level could achieve greater than 50% protective neutralization. So that's why they used this level right here. So if you look at the first panel over here, panel A, this is the anti-RBD antibody level. This is the patients who got Moderna, and these are the patients who got placebo. And this dashed line is what you want to be above. And you can see that many more of the Moderna recipients were above the line than the placebo. In fact, the actual numbers were 55% for the Moderna and 18% for placebo. So you might ask, well, why are patients who get saline developing antibodies in the same way that Moderna is? And we're going to get to that in a second. Now, if you look at graph B, you can see on the y-axis is the anti-RBD antibody. This is in all the individual patients. You can see in those patients who got Moderna, most of them developed an increase in antibody level, whereas in placebo, it's much more of a mixed bag. Some had a bit of an increase, most did not. And then this is the proportion of patients with neutralization after the third dose. You can see it's much higher after the Moderna vaccine. This was what happened with safety. So there's no grade 3 or 4 events. And again, this is the third study now showing no cases of acute rejection. So for local events, there was pain. I think we could all attest to having pain after getting this injection. There was erythema, and then the main systemic side effects were fatigue and myalgia and chills. So there were some caveats to this study. So it was a short follow-up. It wasn't powered to detect differences in clinical outcomes. The authors acknowledged that this 100-unit level was kind of arbitrary, and it wasn't predictive of resistance to infection. And then the small group in the placebo had an increase in antibody, and they said that that was because there's ongoing vaccine-induced B-cell stimulation. So essentially what they're saying is that those patients are still responding to the second dose. That wasn't because of the placebo. So after this paper came out, actually 2 days after this paper came out, there was another joint statement from the transplant organizations, and they changed course to their credits, and they said based on the current evidence, we now recommend providing a third dose of the vaccine to all solid organ transplant recipients, and to do this basically if local regulations allow. So this is what we're doing, as a lot of you probably know. We're doing this very aggressively with our transplant recipients. All right, so that's the story on SARS-CoV-2. Let's change gears now and talk about infections and kidney transplants, keeping with this infection theme. So this was a study that was published in January of this year in AJT. And this study is important because it's the first national look at infections in kidney transplant recipients. So what these authors did, these authors are from Johns Hopkins, and what they did was look at all kidney transplant recipients from 1999 to 2014 who had a kidney transplant and who had an infection. So obviously a very big time frame. So this is the very first national study that's looked at every single transplant center in the US. Prior to this, all the studies were single center studies, and they were actually quite old, so there hasn't been any recent studies. This is a very large study of 144,000 kidney transplant recipients. So because it was so big, they could account for some problems that you have with single center studies, which are things like donor recipient case mix, differences in transplant technique, immunosuppression, differences in infection prophylaxis, and account for patients who lost the follow-up. So the first thing that these authors showed was that the cumulative incidence of infection post-transplant is actually quite high. So you can see here on the y-axis is the cumulative incidence. You can see that in the first year, about 68% of the patients had at least one infection, so a very high number. Prior to this, most studies suggested that the infection rate was closer to 30%. So the cumulative incidence was 53.7%. You can see that the cumulative incidence continues to rise, although it flattens out a bit as you get to year 5. In terms of the kinds of infections you see, there's a whole gamut, but the most common ones were UTIs, bacterial infections, sepsis, and pneumonia. So these are the biggest players. And then very importantly, if you look at mortality, you can see here in the red line, those are the kidney transplant recipients who had an infection. This dashed line are the people who did not have an infection. You can see that those who had an infection had a much greater mortality. And then if you look at graph B, this is death-censored graft failure. So this is just looking at graft failure, censored for death. You can see that that also has increased in people who have an infection. So obviously this is a big issue, can affect both mortality and graft failure. And then if you're curious, that the infections that are most responsible for the graft failure were pneumonia, sepsis, and C. diff. So I guess you might have been able to guess those, but those are the biggest players. So what they concluded was that after kidney transplant, infections are common. We know that that's pretty obvious, but they're actually higher than we expected them to, than we previously thought they were. So obviously we have to surveil for these and be pretty aggressive about treatment. All right, so let's move on now to talk about PTLD. I'm just going to stop here real quick, see what time it is. It's 8:30. Anybody have any questions or comments?
Gosh, I had a question regarding the COVID section, but I don't know if you want me to wait until the end.
Yeah, we could do it now if you want.
So have you seen in the literature any type, maybe this is a little bit different type of studies about concerns about potential transplant recipients with the overall COVID pandemic? So as you know well, and you reported, the patients who have been transplanted and on immunosuppression, they've been the ones more at risk, even when they've been vaccinated, at least with 2 doses. And I think we're learning more with the 3rd dose. But are you seeing a little bit more of resistance of dialysis patients or concerns in studies regarding referral for transplantation?
So I think you're asking, are we seeing patients who are coming for transplant who don't want to get the vaccine? Is that right?
Yeah, and even those who are vaccinated, that's one. And even those who are vaccinated, are you seeing some concern?
Yeah, about getting the booster.
Yeah, or even going for transplant.
Yes, there's the answer to the question is yes. So I've personally seen patients who ask, do I have to get the vaccine? So these are patients who are either stage 5, not on dialysis, or who are on dialysis, and they will ask, do I have to get the vaccine to get a transplant? So we don't actually have a standard, we actually don't have a policy, a fixed written policy for kidney transplant recipients, at least as of 3 weeks ago. But we say we strongly recommend it, and invariably everyone does get a vaccine, because we explain to them that in kidney transplant recipients in particular, there's not a good antibody response. So you don't want to get a kidney, obviously, and then have problems with COVID afterwards. So, but it's an interesting question, Michelle, because when I was in clinic just a couple of weeks ago, the people who were doing evaluations for heart transplants were also being asked the same question. So it's kind of amazing. I mean, patients are willing to have their chest packs open and get a heart transplant, but they don't want to get the vaccine. So the heart transplant people said, for us, because we use such high doses of immunosuppression, and the higher the dose of immunosuppression, the greater the risk, we're going to mandate it. But that was actually, it wasn't a center policy, that was an individual physician. We haven't seen a single patient who's not taken the vaccine before transplantation. So they ask about it, but they do it.
Thanks,
hey,
guys.
It's Patrick from clinic.
We actually just other perspective on it.
Yeah, we actually just this week implemented the policy that it's a requirement for not only recipients, but donors, living donors, to be fully vaccinated to get listed for an organ transplant.
Yeah.
How that's going to roll out for the hundreds of patients who are already on the list, I don't know how we're going to go about finding if they've been vaccinated or not, but moving forward, all of our patients are going to be required to be vaccinated. We've had 5 patient deaths of people who have breakthroughs. So that means they were fully vaccinated, quote unquote, post-transplant, and still developed COVID and died. I think we're at 34 patients now who've developed COVID despite being fully vaccinated. So the importance of getting vaccinated prior to transplant is really paramount.
Yeah, thanks, Pat. Does that answer your question, Michelle?
Yeah, no, absolutely. I think there is a little bit of a small social science study that could be done here, and you could get focus groups of patients.
Yeah.
Who are on dialysis or CKD that are thinking about transplant, and see how the pandemic will change their actions, correct? And what they know about immunosuppression. I think there is some information to be gained here. As Patrick said, even if you're vaccinated, and we know even from UCH data that 20-25% patients who are in the hospital with COVID vaccinated, a lot of them are transplant patients.
Yeah, that's a great suggestion.
Yeah.
Yeah, and then Pat's been doing an amazing job of keeping track of all these guys, and you can imagine what a big job that is. So, all right, if there's any other questions.
So, Kesh, how to motivate giving the vaccine to transplant patients when you just said a lot of them don't get antibodies and a lot of them get breakthrough infections and die? And it's like, well, then if that's happening, why are you telling me to have the vaccine?
Yeah, that's it. You bring up a good point, Charles. I mean, the truth is we don't really know what antibody level is protected, right? We don't know the level that you have to achieve to prevent a breakthrough infection or a more severe consequence. So we're sort of making a supposition that having antibody is going to be good. But the truth of the matter is, we do know that we're extrapolating a little bit from the general population. We do know that risk of death and risk of hospitalization is lower if you do have antibody. You can't tell which transplant patient is going to be able to develop antibody. So you just have to roll the dice and give it to, you give it to everyone in the hopes that they will develop antibody. An interesting corollary with this, and maybe Michelle can speak to this too, but if you remember, when we talk about Hep B vaccines in the dialysis unit, a lot of patients don't develop antibodies to Hep B vaccine, but the rates of Hep B vaccination disease in the dialysis unit has really fallen dramatically in the last several decades. Part of that is because of better infection practice, but a lot of people think that even if you don't have measurable antibody, you still get some sort of protection. So, it's the right thing to do. I mean, getting vaccine is going to help you, I think, if you're going to be on immunosuppression.
Yeah, I agree.
I had a quick question. So it seemed like, based off of the first study, that the general healthy population, that control group, had levels greater than 1,000, and the patients with kidney and CKD or on dialysis, their levels were like 100. So if those patients are in the process of getting transplant, should they get a booster to kind of bring them up before transplant or not?
Yeah, great question. The answer would be yes. Yeah, because if they get the booster after they get immunosuppressed, the chances are they're going to still be at a low level. So that's what Patrick was just saying. Isn't that right, Pat? You want to clarify? So the policy now is going to be everyone should get a vaccine if you've not been vaccinated, but if you have been vaccinated, you should also get a booster.
Well, the boosters, that's maybe it's all semantics here, because the booster currently is recommended for people who are immunosuppressed. CKD, unfortunately, does not fall into that category. So ESRD, even though we know that patient population has a lower immune response to vaccines, they're not included in that booster recommendation. Now, in the near future, we're going to see recommendations to give a third dose or booster to people over the age of 65 and to people who are at high risk. That definition of high risk, we don't know yet. So maybe it will be the individual that's going to get a transplant. We don't know the answer to that one yet. Right now, a booster, a third dose, just because you're on dialysis, you're waiting a transplant, that booster dose, assuming you're not on any immunosuppression, is not being recommended.
Although, Patrick, you don't think that we're going to get to the immunosuppression population pretty soon with boosters?
We're already giving boosters to the immunosuppressed people who are taking chronic immunosuppression, but the person who's on dialysis, they have IgA nephropathy, they're not taking any therapy, they're not on any immunosuppressants. That person at this time isn't eligible for a third dose unless they're over the age of 65, healthcare worker, those categories.
Right, but the question, Pat, is if they come for transplant and they're approved for transplant, then they should get the booster before transplant, right? I think that's what Cam was asking.
No, that wouldn't be recommended at this time, because they should, in theory, have antibody levels, even though they might be lower than the non-dialysis population. We're not telling them to go get a booster just yet. That may all change with recommendations in the coming weeks to months, but at this time, no.
Yeah, I mean, if it was me, I'd want to get the booster before I got immunosuppressed, and I know I'm going to get immunosuppressed, right? We know what the risk factors are for. But anyway,
immunosuppression is not going to wipe away your antibodies that you have preformed.
Yeah, but it's
maybe belatacept to some extent, but the other agents shouldn't. Yeah, even thymoglobulin.
Yeah, but you saw the data. I mean, well, anyway, as everyone can see, this is a controversial topic. It's been controversial all summer. It also stimulated this amount of discussion in Aspen too, so that was good. But yeah, pretty interesting. So I guess Cam, the answer to your question is the jury is still out about that, but it sounds like it's not a policy at our center just yet about getting the booster before you get transplanted. All right, so I'm going to move on just in the interest of time to these last two sections, and then we'll open it up for more discussion afterwards. So let me tell you about a new advance in post-transplant lymphoproliferative disorder, or PTLD. So just some background on PTLD. This is a lymphoid and/or plasmacytic proliferation that occurs due to immunosuppression. It has a bimodal incidence in kidney transplant recipients. So early post-transplant, there's a peak, and then there's also a second peak that occurs 10 to 14 years post-transplant. The clinical presentation is very variable. It can be asymptomatic to having B symptoms and all sorts of symptoms. Now, if you look at the overall median survival, it's not good. It's 6.6 years after diagnosis. If you remember the 10 to 15-year survivals that I showed you earlier, you can see what an impact that this getting this diagnosis would be. In terms of treatment, the treatment is to reduce the immunosuppression, give chemo, plus minus rituximab. Sometimes the patients have to have surgery or radiotherapy for localized disease. And then in terms of the types of PTLD, there's 4 different types. There are early lesions, which are considered benign, polymorphic PTLD, which is a mix of different cell types, monomorphic PTLD, which is one cell type, and then there's other rare types, such as Hodgkin's disease. So there's a paper that just came out in July in AJT, and this was a nested study from a multi-center nationwide Swiss transplant cohort. So basically, every transplant center in Switzerland participated in the study, and they included all solid organ transplant recipients between 2008 and 2019. So this is not a very common diagnosis, fortunately, but you need a big study like this in order to capture a lot of patients, or at least a relatively large amount of patients. So this was primary transplants only at 6 Swiss transplant centers. So they looked at 4,765 solid organ transplant recipients. The majority were kidney, but they also had liver, lung, and heart. The median age at transplant was 54, so relatively young. 36% were female, and the median follow-up was about 4 years. So the overall PTLD incidence was about 2.39 per 1,000 patient years. So again, like I say, it's not a very common disease, but when you get it, the outcomes are not good. So this first graph here shows you the effect of EBV positivity versus negativity on PTLD outcomes. So you can see the PTLD incidence rate here, and then these gray circles are EBV positive, and the black squares are EBV negative. You can see that early on, EBV positive occurs quite a bit, and then it slowly wanes over time, whereas the EBV negative is kind of all over the place and doesn't really have much of a pattern. About 11% of the patients had early lesions, about 23% had polymorphic lesions, and the majority of patients, the most common form was the monomorphic kind. So this is the one cell type kind. This was the most common. Also, the authors observed that most PTLDs are of B cell origin, so 95%. And they also found that extranodal involvement was very common. 87% of the EBV positive and 78% of the EBV negative had extranodal involvement. So you can see here where the extranodal involvement is occurring. It's in the CNS, abdominal organs, intestines, bone marrow, and in the transplanted organ. So what that means is if you got a kidney transplant, you would see sometimes lymphoma in the kidney. If you had a heart transplant, you might see lymphoma in the heart. Okay, now these authors looked at the effect of antiviral prophylaxis on EBV. And what they showed here, the y-axis, you can see these numbers are very, very small. This dashed line here are people who got antiviral prophylaxis. The solid line is people who did not get prophylaxis. These curves are very close together, and basically there was no difference in the incidence. So basically, antiviral prophylaxis has no effect on EBV positive PTLD in year 1 and beyond. But one of the interesting things they saw in this kind of cohort study was that there was 191 solid organ transplants recipients who got rituximab. And most of these were induction therapy for kidney transplant recipients. And most of these, the majority, were because they were doing ABO incompatible kidney transplantation. So this is something that was totally separate, but it was a sort of a fortunate thing that they had all these patients who were getting rituximab. And interestingly, none of the patients who got rituximab, 0 out of 191, got PTLD whereas all the patients who got PTLD were in the group that did not get rituximab. In addition, none of the patients who got rituximab for acute rejection, there was a further 121 patients. So this is on top of this 191. Another 121 got rituximab for acute rejection. In the follow-up, none of those patients developed PTLD either. So here on the y-axis of this graph, you see probability of PTLD. This dashed line is if you got rituximab induction. This solid line is if you got some kind of other induction, and you can see that all the PTLD occurs in this group only. So what they concluded from this was that the incidence of this disease is low, but it's still associated with very noticeable mortality. The incidence of EBV positive PTLD is highest in the first year and declines over time. Antiviral prophylaxis doesn't do anything for PTLD incidence. But they had this novel finding, and that was that rituximab, if it was given as part of the induction regimen, or if it was used as treatment for acute rejection, for antibody-mediated rejection, it was associated with a decreased risk of PTLD occurrence. So obviously this finding needs to be confirmed in independent cohorts, but it's kind of an interesting study. All right, and then the last few minutes here, I'm just going to go over one more trial, and this was a new advance in polyomavirus. So just to give you some background about polyomavirus, there are basically two polyomaviruses. There's BK and JC. They're called BK and JC because these are the initials of the first patients who got these viruses. The BK virus is got a predilection for the genitourinary tract. The JC virus has a predilection for the CNS. So this is a 40 to 50 nanometers. It's got 5,000 base pairs. So remember, SARS-CoV-2 has 26,000 base pairs. So this is a smaller virus. This is what it looks like, and this is what it looks like on EM. So these viruses are very highly seroprevalent in the human population. Up to 90% of the general population are going to have antibodies to both of these viruses by age 4, but neither of them ever cause any problems unless you become immunocompromised. So when you get immunosuppressed, that's when these viruses start to cause a problem. So just by the numbers, about 25 to 30% of kidney transplant recipients develop viruria, so that's the virus in the urine. About 12% develop viremia, so virus in the blood, and then about 10% develop BK virus nephropathy. And then the incidence of allograft failure, there's a big spread here, a big range, 15 to 50%. And that's because it depends on which sensor you look at. A lot of these are multi-sensor studies, single sensor studies. It depends on when you look at the data, but the bottom line is rates have fallen with respect to graft failure from BK virus, but the occurrence of viremia and nephropathy are still fairly common. So this is a paper addressing BK that was published in January of this year, and this is looking at IVIG as a preventative strategy for BK virus, viremia, and nephropathy. So right now we're monitoring for BK, and then we treat it when we see it, but this is looking at a preventative strategy. And this may be something that we'll go to with SARS-CoV-2, because what these authors have done in previous papers was to identify a level of antibody which prevents BK from occurring. So they identified this less than 4 log 10 IC50 against the donor strain. This level of antibody will prevent BK from occurring. So what they did was they looked at patients between 2012 and 2017, and they identified 271 patients who had available levels of antibody against polyoma. And then they identified 113 of those patients who were at high risk for polyoma, for BK virus replication. And that's because they had low levels of antibody. And they identified a further 154 patients who were at low risk for BK replication. And that's because they had high levels of antibody. So these 113 was divided into 41 high risk untreated patients. So they never got anything. And then they had a further 44 patients who got treated with IVIG. In this low risk group, they had 89 patients who were at low risk and they were untreated. So basically you had one group of untreated patients, one group of patients who were high risk and treated with IVIG, and one group of patients who were low risk. And so this is the survival probability, and this is survival from BK virus. So this dashed line is the high risk patients who had low levels of antibody, who were not treated. This gray line is patients who are low risk, not treated. And this darker line is the patients who are high risk and they got IVIG. And you can see that if you got IVIG, you were high risk, you basically start to behave like a low risk person. In addition, when they did a multivariate analysis of the risk factors associated with viremia, the biggest thing that fell out was that if you were high risk and treated, so you didn't get IVIG, you had a very high risk of getting BK viremia. And then when they looked at BK virus associated nephropathy, again, the curves look very similar. This is the high risk group, this is the low risk group, and this is the high risk treated group. And the high risk treated group looks like the low risk group. So basically what these authors found was that if you gave IVIG, you would increase the neutralizing antibody titers against BK in the recipients, and it would put you over the protective threshold. So passive immunization, in their opinion, with IVIG was associated with a significant lower incidence of both BK viremia and BK nephropathy. So, so that raises a couple of interesting thoughts. I mean, could you screen all patients for the presence of antibody against polyoma, and if it's low, then potentially give them IVIG. So this needs obviously a randomized controlled trial to confirm that this approach works, but it's kind of a neat way of trying to match the antibody level with the natural outcome. I think that's my last slide. So yeah, I'll stop there and open it up to questions and discussion.
Thanks, Kesh. That was really a nice presentation and tour de force. What were the major comments when you presented in Aspen?
Yeah, at the time when I presented in Aspen, the third dose wasn't being recommended. So a lot of people were upset by that. They were asking, I mean, the data is the data, it's pretty clear. What is this sort of vague rumor that there's acute rejection associated with the vaccine or with boosters? Why aren't we giving it? That was sort of the predominant opinion of the group, and that eventually came to pass, that we're now giving the booster dose to immunosuppressed patients. So that was the big takeaway. That was everyone's interest was really about the SARS-CoV-2, which I figured it would be. That's why I spent so much time on it, because that's super interesting.
Hey, Kesh, that BK paper with the IVIG,
Yes.
I remember seeing it, and the dosing was pretty low. Like they were using IVIG only 3 doses. But do you remember when they gave the IVIG? Was it right at the time of transplant? Was it later on post-transplant, or when did they start that IVIG therapy in that high-risk group?
I think they were giving it either at the time of transplant or for antibody-mediated rejection. So it could have been before or after. So then they would then collect the data on what happened after they got the IVIG. Yeah, I have that paper. I can send it to you.
Thanks.
All right, great. Well, if there's no other questions, or if you've got questions you want to ask me later, just drop me a line. And yeah, thanks very much.
Thanks, Kesh. Appreciate it.
All right.